signing in, so I will try and give them a few seconds, but we will go ahead and begin while they're joining. Hello from Washington, DC. Welcome to the webinar on the Community Resource Information and Exchange Initiative, CORI. My name is Sylvia Shirima, and I'm the Health Education Manager at the George Washington University Cancer Center. Before we begin, I have some few housekeeping rules. All of you are muted and will be muted throughout the call. If you have any questions for the presenter, please use the Q&A feature on Zoom and not the chat. Time permitting, we will address all questions at the end. If it's a clarifying question, feel free to ask during the session, but we prefer at the end for all questions. Today, we'll be hearing from David Poms on the process implementation phase of a pilot program here in Washington, DC. David has 10 years of experience working in Washington, DC on social equity programs related to education, food, and health. David kindly coordinates the DC PACT initiative, a cross-sector health coalition addressing social determinants of health, which builds on his experience in strengthening the capacity of the emergency food assistance network of the greater Washington, DC area, advocacy, outreach, and education at City Year, Washington, DC, and as a servant leader intern and youth advocate leadership trainer with the Children's Defense Fund. David is currently developing the new DCPCA member capacity building initiative related to health equity and structural determinants of health. Without further ado, I would like to welcome our presenter, David. Welcome, David.
Thank you so much, Sylvia, for the invitation to present today. I'm excited to talk to you all. Let's see, it's always an experience to see my face up on the screen as I'm being introduced. It sounds impressive. I hope you find the work that we're doing to be of interest. I always love to know a bit more about what folks do and who I'm talking to. So I saw a couple people introduce themselves, but I'd love to know, where people are from. And, I would love to know what kind of social determinants work you all do, but that might take too much time. I feel like I learn as much from people in these sorts of webinars as I get out of it or put in. So I'm happy to talk about this and happy to also talk to folks about this following the webinar to learn more. There's some links and things that I can point you to as I go through as well. So I'm going to start off talking about DC PACT, the Positive Accountable Community Transformation Coalition. We love acronyms. We are a collective impact coalition. We'll talk about what collective impact means. Many of you are probably familiar with that. But I like to start off first with elements of our common agenda, which is a collective impact piece of the puzzle, talking about our problem statement, problem that we're seeking to address in our vision and mission. And I'm going to talk about in this presentation sort of how we've arrived at these key elements. We also have a number of strategic goals that we're looking to accomplish, working in the area of social risk management, working in the area of dialogue and action on social determinants, also looking at health technology and on well-being assessment. We think those are crucial strategies to achieve our vision. The techniques that we use are named in our mission statement: community leadership, policy change, infrastructure development, and care improvement. So why are we doing this? Well, DC PACT is, as was mentioned, is a coalition. We are at the DC Primary Care Association, where I work, serving as the backbone of that coalition. If you're not familiar with the Primary Care Association model, there's one in every state, more or less, representing community health centers, federally qualified health centers. So here in DC, we work very closely with the federally qualified health centers who have been leaders in health equity and action in the city for, we just celebrated our 25th anniversary as the DCPCA. We were founded by many of those health centers in 1996 as part of the push to increase healthcare access. We were leaders in DC and here on the ground, but also nationally in the push to expand healthcare access, culminating in the Affordable Care Act and everything that we did to expand access. But the thing that we recognized when we started PACT was this greater recognition that, we continue to face tremendous health equity challenges that couldn't be solved just by access and coverage alone. And so we arrived at, through PACT, sort of our response to how do we begin to address social determinants of health. And so this is the overall big picture. The two models that we use, the accountable health community model is one. This was started as a Center for Medicaid and Medicare Innovation pilot program. 32 sites across the country were funded to implement this model of screening and referral to services that can meet beneficiary unmet health-related social needs. And we have, throughout the process, tried to build up a model that can support, we've tried to build up infrastructure that can support the implementation of this model across the city. And so that's our community resource information exchange, CORI. I'm going to refer to it as CORI. And I'll talk more about how we've arrived at that system. The other thing that we've done through DCPACT is implemented the collective impact model. And so, again, I think probably most of you have heard this term. Certainly they're great buzzwords, taste even better together. The idea with collective impact, and we've done some training around this, is that we're trying to work together to arrive at solutions that we don't know at the outset, focused on a discrete problem that we're trying to solve. And so we've brought together a great number of health, public, and social service organizations through this model, using work groups as our key sort of method of progress, getting together in a process of determining the scope of the challenge, grounding ourselves in data, designing short and long-term strategies, in particular short-term strategies that can build buy-in, and seeking to drive implementation across our four key strategic goals. And so that has allowed us to make a lot of progress, I think. So I'll credit the collective impact model, not only with helping us to implement the accountable health community model, but give us as a coalition the complementary pieces that we think have to be in place, not only for screening and referral, but really to go upstream from there and do prevention and upstream work. So how did we do that? So we have an origin story like any great superhero. You can see the number of our partners on the left-hand side. I mentioned the CMS, Accountable Health Community Pilot. So we came together to apply for that. DCPCA's path to leadership around access and coverage really meant that we emerged from all of these partners sort of as a leader in this space, recognizing our past leadership and wanting to continue that in our role as primary care people who care about public health. So even though we did not receive the funding from CMS, and if there's anyone from CMS on this call, no hard feelings, but we decided to keep working together. And we decided, with some support from some of our public funders, the DC Health Department and Department of Healthcare Finance, which is our Medicaid agency, to really keep trying to tackle this problem and figure out, what does it mean for us to address social determinants? We knew at that time that CMS was likely to keep funding elements of the accountable health community model in the future, that there could be some ways that our health centers would want to be involved in that. And so we decided to keep going. We used the collective impact model to create our common agenda. The vision, mission, and problem statement that I showed earlier, those are the ones that we've updated as of 2021 at the bottom there. So we started with the first common agenda and moved into our second one now. In 2019, we received funding from DHCF, again, Department of Healthcare Finance, Medicaid, to do the planning for what became the CORI initiative. And we were able to capitalize on high-tech funds. We were the first city or state to receive high-tech funds for social determinant, social need technology development within the HIE that we use here in DC. And so I'll talk a bit about how we went about doing that. And so we're now pretty far along. We're into a third phase of technical development with Corey that we're just getting started. But the way that we started that was, again, without having any sort of CMS work, we came together through a series of summits. DC Medicaid was instrumental in pulling folks together for this. We had a summit where we brought together local and national experts to talk about what we're doing, what the requirements for a technical system that could support everyone's work would be. That was documented in our 2018 state Medicaid health IT plan. We've again since updated that plan. You can see a link in the bottom right that really goes into how we see social determinants of health use cases fitting into what Medicaid wants to see happen in the provider community in the city. So really great support from and collaboration with DC Medicaid to pull together all the information necessary for us to receive this high-tech funding and now subsequent Medicaid technology funding for continued use of this set of tools and development of those tools as well. That collaboration took a couple forms. So even before the needs assessment, there was just our action team brought together folks from Medicaid and all sorts of district stakeholders to talk about, what would it look like for us to have a citywide network of health providers, social providers, our respective funders and payers that could collaborate using HIE. We did an environmental scan. We looked at a number of systems that were out there. We also, as I mentioned, were funded by DHCF to do a needs assessment. We worked with a consultant partner in the space of government and health to do interviews and assessments and focus groups to try to understand, again, like what are the short-term and long-term functions that would make this something that people would champion and come together around, recognizing the sort of need for systems to be in place that meet people's needs at every step of the way as we're making those changes. And so we came together to come up with a number of findings that led to our recommendations for the technical solution. So the first is that we wanted to prioritize ease of use, that it was compatible with existing EHRs, compatible with existing CBO tools and workflows, and that we wanted an iterative process. I will say this is probably, out of step or maybe a different set of priorities than many states have taken with their approach to this question of what are the technical solutions for social need resolution. I'll talk more about sort of how we weighed whether to buy or build or bridge some of the technical solutions. But also other pieces of this include, sort of some of the domains. Who are the partners whose needs, tools, and workflows we should take into account when building this out? We identified food and housing in this category of social wellness, behavioral health providers as, the CBO stakeholders who we should make sure this first iteration of the system should be compatible for, prioritizing, in a user-centered design process for all parties, health and social service providers, ways that the HIE can support their work. And a sort of consensus building process, domain by domain, was decided on to sort of continue to work with partners in each domain. We also, I think this is again a piece that is maybe different than how some people have approached this with the screening question. We did a lot of work in the early years to look at screening tools. There's all sorts of tools that are validated. We've worked very closely with the Gravity Project, followed their lead on this. And one of the things that the Gravity Project has done, if you're not familiar, they're working with HL7. If you're not a health technology person at all, it doesn't really matter. If you are, then you know what I'm talking about. But essentially sort of standards for different clinical and social terminologies to come together and be structured in a way that can make exchange of data easy between systems. And one of the things that project revealed for us when we really studied it, again with a DC PAC working group to sort of on an ad hoc convening basis decide, how should we as a coalition approach the question of screening. We decided that we did not want any sort of standard screener to be the one official screener that all PACT partners would, be looked at to use, or that all Medicaid providers should be expected to use. What we wanted to focus on was standardizing a set of conditions, what we called an answer set to the screening questions, that could mean roughly the same thing and be structured in a broad yet specific enough way that we could get a generalized understanding of the social needs that any given population might have, no matter what screener might be used with that population. And so that had implications for how we wanted to approach the technical solution procurement process, because we knew we wanted to incorporate screening that was based around Z codes and leveraging standards that could allow that to happen. And then we also, of course, wanted to enable some closed loop referral capacity. I think that's generally accepted as health-related social need technology support that folks want in this space. So in our needs assessment work in 2019, working with our consultant partner, Clinovations, we presented a couple of different options: buying the license for a third-party solution, making that license available to Medicaid providers, building out functionalities that mirror many of those but are more customized to our particular system, or bridging those two efforts. And what we arrived upon was this sort of this idea that we would build upon existing current DCHIE capacities, identify where the gaps are, and try to work with the third-party platforms to maximize the sharing of data, optimizing existing workflows, and really focusing on iterative development and quick wins. I mentioned that sort of iterative, step-by-step piece a couple of different places, and I can't stress enough how much we view that as a really valuable part of the way that we've gone about this process, working with many different partners to say, what can we deliver using HIE in the short term that will keep you engaged and committed to building out a broader system. And that's really been the way that the DCHIE has been built out. So the DCHIE, today has a pretty broad set of users across the city. All of our hospitals, most of our nursing facilities, home health providers, all of our federally qualified health centers, 8 community-based organizations that have begun coming into CRISP partnership as a result of the CORI initiative. And that number we expect to grow in the next couple of years as we bring more community-based organizations into the system to be using screening and referral tools in direct communication, bidirectional exchange with health providers. So this just gives you a sense of the size of it and who we're trying to serve with these functions. Another view on the HIE. So right alongside all the rest of the functions that you would expect in an HIE, alerts, patient care data, consent, and care management stuff, we're building out 3 functions: the community resource inventory, which is part of our directory suite of capabilities, and then a brand new suite of capabilities around screening and referral that I'll touch on more in a moment. So all that said, what exactly is CORI? There's a couple of different ways that you can think about it, and I've referenced them in a couple different ways. So first of all, it's primarily a partnership. Medicaid, DHCF, CRISP, which is the city's designated HIE. They also serve Maryland, West Virginia, Connecticut, a number of other states as a statewide HIE. And we're committed to working together to supporting and really sustaining the solutions that are being built out. So sustainability has been a key feature of how we think about designing these functions. And that's a piece of why short-term wins has been kind of a piece of the puzzle for us. Again, the 3 functionalities are CORI, and screening, inventory, and referral constitute those 3 functionalities. We've looked at as well analytics as a 4th functionality. for now, we've focused on these three, but we think that especially when it comes to population health management related to social needs, there's a suite of analytic tools that we're going to eventually want to make available to all of our query users, including both medical and social service providers. Query also refers to our vendor agnostic approach. So we want to share screening and referral information regardless of how and where it's collected. So that means that care partners can view the same information in the HIE regardless of the platform that they use and where it was originally collected. And so we've begun to sign agreements with vendor platforms like Find Help on Bertha to share referral information about patients directly into the HIE using patient matching technology at CRISP to really make that happen on the back end. And then it also refers to, just in general, this sort of interoperable approach that we've taken. And part of that interoperability, I'll say, is, first of all, it's built into the nature of an HIE to be interoperable, primarily between medical record systems, now also with social care and referral systems, even technologies that CBOs are using to manage their services. But that interoperability also comes with this need to foster a culture of shared responsibility for ensuring that your part in the puzzle here is covered so that all parties can ensure and rely on the data in the system to be actionable. So we try to not only connect people, but really build out governance relationships that ensure that people can continue to rely on the information in the database and about patients. So we've done a lot of engagement. Over 100 representatives from various stakeholders in the area have participated with us. We've had a special CBO design group to look at our screening, referral, and inventory tools from the CBO perspective. The key piece about that CBO group being that they're non-HIPAA covered entities. So governing access, really like role-based access technology for CBOs to be able to access information and use the CRISP referral tools without being able to necessarily see HIPAA covered information. We've convened an action team of community resource data stewards. So folks in the DC and really in the broader area who are maintaining information about resources. How do we make sure that the best and most reliable information about the resources available to patients can be found within CRISP? So that includes government agencies, the Department of Behavioral Health, Department of Aging, Department of Health, anyone who is maintaining a list of resources for a given patient audience. We're trying to bring them together to collaborate in making sure that our inventory is most up to date. That has also required us to serve them with some new functions or work on building out functions for them to be fostering their ability to contribute to our list of actionable data. So that has been one lesson, is really focusing on data stewards about community resource inventory. Another piece, I mentioned this already, our standardization action team, which is where we developed the need for Z codes to represent an answer set around health-related social needs being identified, and the implications for that in terms of how we approached procurement. And then finally, we have a HIE policy board in the city appointed by the mayor. We've developed a subcommittee of that policy board to basically govern rules between data stewards for the community resource inventory, as well as structuring how that information gets made available. One of the key pieces of that is we want to publish data about resources available for anybody to use. But when you publish it for free, we also have to make sure that that the data can be relied upon, that there's stewards and maintainers who are there who can receive some benefit for making that information available in a structured way. So developing governance standards has allowed us to begin talking to some of those stewards about, for example, partnership agreements where they are responsible for maintaining information. Let's say the Capital Area Food Bank becomes a partner to the policy board and agrees to share and maintain information about food pantries in the city. and they would get some benefit in return potentially. That's the type of thing that that policy board is looking at. I mentioned as well the Gravity project. We are at the forefront with them in terms of testing some of the standard data sets that they've developed. So again, that includes Z codes, diagnosis codes for health-related social needs for patients, structured metadata as it relates to existing screening tools. Also includes structured data around what sort of goals a patient has, incorporating patient-reported goals for health-related social need resolution might look like someone who has been identified with, 5 or more social needs, but their priority today is food, or their priority today is housing, and maybe the other pieces they don't look at as a problem. How do we put the patient at the center in social need work? That is one piece that we think the structured data can help us with, is to understand what sort of goals patients have with respect to this, so that we're not just assuming screening and referral as the appropriate intervention. And then as well, categorizing and taxonomizing all the interventions available in order to make that, again, structured data that can be exchanged between systems. That said, of course, about screening, we do have a minimum set of screeners, which particularly our Medicaid managed care organizations are using. And they're available for other providers to use as like a preset screener if they want to adopt one that can be used within CRISP in a structured way. So there's that resource for them. And then now, in particular, we're doing a lot more recruitment and promotion to bring, like I said, more community-based organizations online, promote the use of the e-referral tool to make more of the handoffs, whether they're a warm handoff between organizations or a cold handoff of telling somebody about a resource that can meet their need. We want to make sure that we're making more of that visible so that we can begin to evaluate longitudinally how some of these interventions are affecting people's health. And some of this is, some of what I just mentioned is upcoming work that we're doing. Again, that SMHP, State Medicaid Health IT Plan, put a link in the slide earlier, really outlines this in more detail. But we have goals around, particularly making access and exchange of information more supportive, bringing in more housing and nutrition organizations and public agencies that work on those issues into the HIE, refining the functionality. We're working on CBO to CBO referrals using CRISP. It's not a use case that's covered right now in HIE regulatory work, but we're working on that, as well as consent, more granular consent technology that can allow for referrals to be made. And we're doing some use case work. The Gravity project is a great resource on this. They're currently funded by the CDC to do public health use case development for chronic disease prevention. We're developing on the ground some use cases around our health centers for how they want to use the data that we're capturing to maximize value for population health, for patient encounters. We want to look at the issue of, are social needs being resolved when we screen and refer as a key metric of all this? And so understanding, what's blocking people from having those needs resolved? How do we create a better care environment and risk environment for people? Governance is a key part of that question. And so incorporating not only the resource inventory as like a list of resources, we don't want that to be static. We want that to be updated. So that requires some active governance, but we also want to incorporate more CBOs, other less represented groups, into the governance of HIE overall. A key part of DCPAC's vision has been this sort of health and social service silo problem. We need to overcome that. And part of that is sharing power in the healthcare system with community-based organizations on the ground who are able to come in and help us see problems that maybe our healthcare providers aren't seeing in terms of meeting some of these needs, which has been a key part of our progress, is talking to those community-based organizations. And funding pilot projects, testing specific value-added collaborations launching those eventually as Medicaid funded initiatives, or looking at how, these sorts of referrals are adding value to health outcomes, and how can we launch those from pilot into standard operating procedure. So that's what we envision through the upcoming work on Corey. And Corey is really our technology piece and the way that we want to visualize a lot of the social risk information that we're gathering. I'll just say for DCPAC, we want to build capacity at the organizations who are using Corey for change, so that they can better access and utilize Corey tools and other upstream social determinant tools for system change. Part of that has meant building shared measurement consensus. Shared measurement is a key part of collective impact. I mentioned an outcome that we think is a key shared measure, which is screening and referral resolving people's social needs? Well, I'll just tell you that when CMS evaluated the accountable health community interventions, something like 75% of individuals who were screened were offered navigational support. Only 14% of them had their needs marked as resolved. So first of all, we need to understand here in DC, what is that number? We need to start measuring that. And then we also need some upstream measures that tell us, before we get to screening and referral, how do we have a framework in place that moves us to a more seamless, accountable community? Not only looking at resolution on the ground, but well-being, prevention, and pieces like this. So that piece of it, I'll just close. I know the focus has been on the technology piece, but I'll just say a key part of our progress on technology and Corey has been PAC's ability to say, all of this is in service to, again, these problem statement, looking at all the way at the beginning, the lack of accountability, the lack of alignment and investment has led to these inequitable conditions. And so we can align, but we also want to increase accountability and eventually increase investment to make the vision and mission come true. So I'll close there. Happy to take questions at this time.
Thank you so much, David. That was very, very useful. A lot of new information, the importance of collaboration from inception to driving implementation, a lot of interesting information, and how to start was good to learn. And I hope everyone enjoyed. We do have some questions, but feel free to continue asking questions, or if you need any clarification, just drop them into the Q&A part of the app. So our first question is from Ian Khan, and they are asking if in case you didn't mention it, how much funding did you receive or was needed to create the tool?
Yeah, good question. So our first couple of years, we were receiving some funding from the DC Health Department, as well as our Medicaid agency, to answer some discrete questions, particularly related to chronic disease management and how social determinants comes in. So that funded, basically part of my position, part of my boss's position. Wasn't a whole lot. DCPCA, as an institution, we have a policy team. I'm part of our policy and partnership team. And so it was sort of an open line that our health centers wanted us to work on and help answer through partnership. What do we need to do to create these tools? In 2019, the DC Council included $500,000 for DC Medicaid to do the needs assessment on creating a system. And that's what led us to that slide I showed a moment ago of, do we buy, do we build, do we bridge, and all the information that we collected on that. So that $500,000 funded us. It funded Clinnovations Government and Health. It funded the DC Hospital Association, and it funded, actually it's just those three, to talk to our members, talk to folks on the ground to get all the information that we put into our needs assessment. And I can put a link to, actually, do we have that? Maybe we don't have the full thing online, actually. But so that was the $500,000. And then that money we leveraged through Medicaid, actually through high tech funding, through a match with the federal government. And so the work that we started in 2020 and wrapped up at the end of 2021, it was a 90-10 match of that $500,000. So something like $3 or $4 million at the end of the day, to build out the current functionalities that we have around screening, inventory, and referral. And now we continue to receive funding through Medicaid. I know the acronym is MES, but I'm blanking on what that stands for, but it's essentially money that HIEs receive at the Medicaid matching rate with the federal government. So the city puts in some and the federal government matches that to continue to sustain these tools. And that funding is sustained. So year over year, they'll continue to have funding to support those tools. And we have some funding through that to do continue to talk with users, help inform how the tools progress. DCPAC is a separate piece related to Corey that DCPCA continues to fund through our policy and advocacy work. Hopefully that answers the question.
Thank you. The next question is asking, can you speak more about SDOH questions that are asked? Who asks them? And what EMR software is prominently used in DC? Do you get consent from the patient? Or do you use the HIPAA release type of form to get the data?
Yeah, so all good questions. I think the question of what software is available drove in some of the decision making. All of our health centers in DC use eClinicalWorks as their medical record system. DCPCA is the state, city, ECW vendor on behalf of our health centers. So we actually do technical support to our health centers on technology that they use every day. So that put us as well in a great position to really evaluate new technology. We do that anyway with our DC Medicaid agency a lot. All the hospitals and other medical providers, there are many that use ECW, but the hospitals, I don't think any of them use ECW. Some of them are on Cerner, some of them are on Epic. Children's National Hospital in DC, I don't know if anybody's on from Children's National Hospital, but they have a network of different practices that there's probably 4 or 5 different EMRs that are used. The question of how will people access some of this information, I showed a slide earlier that showed you how people access CRISP. So that's really the most prominent technology system in terms of number of people that can use CRISP. And so that's why we chose to locate a lot of these functionalities within CRISP, is because whether you're using ECW or Epic or Cerner, if you're in DC, you probably have access to CRISP to seamlessly manage an individual's data that might be coming from another source. So that's part of why we put it there. I'll also say in terms of the SDOH screening process, I mentioned earlier, we backed off of trying to assign a particular set of SDOH screening questions to be asked. We chose instead to use the Z code approach, mapping particular Z codes to particular answers. On one screener, you might be asked, how often in the last month have you run out of food? On another, it might be how often in the last year. But 2 different answers to those questions might still broadly yield you Z59.4 moderate food insecurity. So that type of mapping was necessary and allowed us to we didn't actually even need to do all the mapping to the screening tools. We could just say, ask the questions you want, your providers choose the Z codes that you want to assign based on the process that you have in your practice. So that practice level decision-making was also a piece that we tried to preserve in order to enhance uptake on the systems. And that, with our FQHCs, I would say was a big success. Many of our FQHCs work with different funders for different programs who have different screening requirements, allowing them to decide the Z codes that were assigned based on the process that they have in place. Some FQHCs might have a registrar or a receptionist asking a question. For some people, it's a social worker that they would get referred to. We have a couple different bundled payment programs, the Ryan White HIV program. We have a health homes demonstration project called My Health GPS, where there's some specific questions that are asked. But the nice thing about our screening functionality is that it can display all of that information as long as the people who are recording that information use a Z code to include that in the care document that gets sent from the medical record system to the HIE. And then as far as consent, I see the last question. And here we have an opt-out process for the HIE. So anybody who would be coming to an FQHC as a patient, would be signing a release or opting out of having that information shared with CRISP. And we're working on a consent tool within CRISP that would allow for more granular data sharing. Right now, you could share that information, and anybody on a care team that's working with you at any organization could see that information. We are working on it to where maybe you only want to have some members of your care team see information that's personal. So that's a piece that we're working on right now.
Thank you. The next person is asking, how do you engage partners and collaborators in the process of sharing power, especially when working between social care and healthcare organizations that have different structural and funding situations?
Mm-hmm. It's been a challenge the whole time that we've had DCPACT to answer that question. When I started at the Capital Area Food Bank, and began managing some of the education programs there, I got connected to hospitals that were trying to address food insecurity issues. And it was stark, at the time we thought that the hospital community benefit money was going to be flowing to organizations that could address social needs. And it was a stark situation in some cases when we realized like how difficult it would be for us to actually have our ability to deliver services be something that was preserved in the way that we wanted to deliver them in a healthcare setting. So a lot of structural just understanding of how to work with patients or clients. It was a revelation and even a recent meeting that, if you're a CBO, you're usually not promoting your services that much, or maybe you're promoting them to a specific audience, but when it comes to a food pantry, most of the time people are going to get there, even if you don't really do much promotion, just by word of mouth, even before they show up in a clinical setting. You probably trust the people at the pantry a lot more than they trust you, to be honest. So thinking about how to preserve that has been crucial for us. We've done paid stipends to CBOs to participate in, for example, our design group sessions to get their feedback on the actual tools that we built into the HIE. I, myself, and my colleague at DCPCA, Patricia Quinn, I say colleague like she's not my boss, we, as representatives of the Primary Care Association on our policy team, we are really in the business of building relationships with organizations that our members serve. Or who, let me say that again, we're in the business of building relationships with government and nonprofit and anyone else. Organizations on the social care side, we go out to them, we go to their coalition meetings, we represent and show up as much as we can, because that's part of the process of power sharing, is showing up for other initiatives and making what we're doing primarily something that they can harness to achieve their goals has been probably the best way we've been able to really try to share power. So I'm pretty involved in DC's Healthy Housing Collaborative. I'm pretty involved in DC's Food as Medicine Collaborative. We have all, 5 or 6 other collaboratives working on clinical community linkages. And if it's a clinic community linkage, I mentioned earlier, DCPACT has a goal around stakeholder engagement and communications. And part of how we achieve that is, again, just showing up. And moving on to folks sort of participating in this, it looks like getting to a place where policy and systems can support social care organizations to deliver services in a client-centered way. a big goal for us is enabling social risk management services to be compensated through Medicaid policy. We won a Medicaid waiver recently for our permanent supportive housing program to receive Medicaid dollars. That was a 6-year process that our DC Department of Human Services went through in collaboration with our Medicaid agency to apply for and receive support from federal Medicaid to structure our program and bill Medicaid in a way that was allowable. I know there's a lot more progress that's happening in other states. I know California has made some progress that's exciting in terms of Medicaid waivers and other ways that they're making social care partners more integral to the system. So I would say that sort of like service provision, to the extent that we can begin to really incorporate those social care organizations into things like Medicaid, I think is the way that we're trying to, basically sell social care organizations on working with us. They don't necessarily need a whole lot of referrals, but what they want is to better meet their mission. And so it's key to understand their mission so that we can figure out how to best support them to in their given situation.
Thank you. And the last question here is asking about, do you have any guidance, advice on how the system and technology might be replicated in cancer care settings or adopted?
That's a piece that I would love to learn more about is, some of the specific cancer care SDOH challenges that might be common situations, because I think it's one that even with, GW and some of the other cancer centers in DC, we're beginning to look at, using the CORI tools for these sorts of processes. I think, it's probably broadly similar to, in a lot of ways, more general healthcare uses for these sorts of tools. I think one thing I'll say about it is we're trying to build up a network of organizations who can receive referrals and provide social care services. What that's looked like thus far is a lot of specific relationships between specific providers and specific social care partners. Getting to a place where a social care service can be like a waiver type service, where it's a benefit that any Medicaid person and any Medicaid beneficiary could expect to receive, is different than where a lot of these services are, where maybe the Capital Area Food Bank has a food pantry with a particular site. How do we get those existing clinic community linkage systems into CORI, into the HIE, so that we can provide better outcomes data to them and build the case for some of these services as benefits, I think is broadly the way that we think these clinic community linkages will go. To the extent that there are these sort of recurring social need situations for cancer patients in particular, and having supported my own mother with her breast cancer and dealing with health-related social needs as a teenager, I can certainly think of several, cost not being the least of them, and how do you meet needs while you're dealing with a care regimen that is quite specific in many cases. I think it also, just thinking about that, not only is it cost, but I mentioned earlier our priority domains of food, housing, and wellness. Wellness and isolation, I think, are really key. I know you all do great work to bring folks together, to support each other, to support patients, have patients support each other. I think that sort of thing is a broader social need that may or may not be a screen and refer type situation. Nonetheless, using these systems to evaluate outcomes, evaluate upstream interventions, who are the types of patients that we need to intervene earlier with specific social needs, to make sure that they're not getting to a place where there's an at-risk or crisis situation. We're just starting to think about, from a population health perspective, what does this data mean for us, that we now know these services that meet these needs are available, and there are these patients with these Z codes. So I think for us, getting not only the providers, the social care providers, but even patients involved with defining some of these use cases, I think is going to be key in any setting, whether that's primary care, cancer care, other sorts of providers that are doing this work.
Thank you very much. We will share the slides and the recording of this webinar to all our attendees. And with that, we've come to the end of our session. Thank you so much, David, for your time. And thank you to all our attendees for attending. Have a good afternoon.
Feel free, if anybody would like to, I'll put my email in the chat. I'd love to hear from you and talk to you more about any questions that you have.